Hello and welcome to today's Black Health program, and I thank you so much for joining us. I'm C. Virginia Fields, former president of the Borough of Manhattan, and now president CEO of the National Black Leadership Commission on Health. And our mission is to work to eliminate health disparities and promote health equity through action, policy, and advocacy. And today we will discuss colon cancer. Our focus primarily is on 8 areas of disparities that disproportionately impact Black Americans, or I should say Black populations. And they include HIV, hepatitis C, cardiovascular disease, prostate cancer, breast cancer, sickle cell, diabetes, and mental health. And of course, the death of Chadwick Boseman has now shed light on colorectal cancer, caused all of us to pause and think, what is this disease that has killed our superstar Black Panther and so many others? And to discuss this today, I am delighted to be joined by Dr. Fola May. Dr. May is an assistant professor of medicine at the University of California, Los Angeles, UCLA, director of quality improvement in gastroenterology at UCLA, and co-director of the UCLA Global Health Education Program. She conducts research in preventive health care disparities, cancer prevention, and international systems of healthcare delivery. The May Laboratory at UCLA focuses on reducing racial and health disparities in cancer outcomes with the focus on colorectal cancer. So welcome, Dr. May. It is such a pleasure to have you join us. Let me just highlight a few comments that you made in a recent CNN interview that certainly I think touched all of us. When you said, while you are not the doctor and cannot speak to the specifics of Chadwick's clinical course with colon cancer, but as a physician and a cancer researcher who has focused her career on disparities in colorectal cancer, I take no pride in sharing that my profession has failed at controlling this disease. Colorectal cancer, you went on further to say, is the second most common cause of cancer-related deaths among men and women combined in the United States. And while traditionally a disease of older adults, it has crept into younger and younger age groups. There are also racial and ethnic groups that see its devastating consequences at a higher frequency. And this heavy toll is particularly ironic given that the disease is largely preventable and 90% of the causes are curable if caused earlier. And back to your comment, you take no pride in sharing that your profession has failed at controlling this disease. With that in mind, Dr. May, please just talk to us about how common this disease is and the fact that it is occurring in younger adults and a few other areas that we're covered in the time that we have together. So welcome.
Thank you very much for having me. It's an honor to be here, and I'm really thrilled to be able to share as much as I can about this disease. A lot of people don't realize that colon cancer or colorectal cancer, so the combination of colon and rectal cancer, is the second most common cause of cancer-related deaths in the United States. I think frequently we hear about breast cancer, prostate cancer, and lung cancer, which are also leading killers. But there is a bit of stigma about talking about cancers that involve the colon and rectum. And I think we have suffered inappropriately because it's a type of cancer that people don't like to talk about. I'm often shocked when people meet me and they're hearing for the first time that Black Americans are more likely to die from colon cancer than white Americans, or that colon cancer is the second most common cancer killer. So I wanted to just start by just impressing on everyone how common this is. And many of us have, if not a personal history with colon cancer, a family member, a friend, or a family member of a friend who's battled this disease or know of someone who has.
Absolutely. As a matter of fact, a friend of mine underwent surgery last year, and thankfully he was diagnosed very early. And after a year out, following a recent exam, it appears that he continues to do very well. But it came about as a result of a regular colonoscopy examination. So how does colon cancer disproportionately impact Blacks? Because those numbers seem relatively high, well, among all of the other diseases that disproportionately impact Blacks. Can you speak to that?
Absolutely. And as you said in your introduction, unfortunately, Black Americans suffer disproportionately from many conditions in the United States. Our number one cause of death is heart disease. 24% of deaths in African Americans are heart disease, but just after that is cancer, with 21% of deaths in the African American community from cancers of all types. So we have a lot of work to do if we want to improve the overall health of our community, and we can focus on heart disease and cancer as areas to do that. We know that African Americans are 20% more likely, or have, actually I should say, African Americans have 20% higher rates of colon cancer than white Americans. And we also know that African Americans have 40% higher death rates from colon cancer than white Americans. So not only are we more likely to get the disease, but when we get it, we're more likely to die from it. And there are many things that are causing this. We think that some of it has to do with risk factors for disease, but a lot of it has to do with early detection and treatment. Common risk factors for colon cancer include dietary factors and lifestyle factors. So diets that are high in processed meats and red meats are increased risk for colon cancer, and diets that are low in calcium and low in fiber are increased risk for colon cancer. And African Americans are more likely to have those diets that are high in meats and processed foods, low in calciums, and low in fiber. So unfortunately, we think that is playing a role. It's not just the patient, though. There are problems with the healthcare system. We know that we are often not as insured as our white counterparts. We have lower insurance rates, which gives us access to care. And when Black Americans see providers, it is less likely that they are offered the recommendation to get screening for colon cancer. And we know that colon cancer screening is very effective at preventing the disease and detecting it early. In fact, since we've introduced screening programs in the United States in the 1990s, the overall rates of colon cancer have dropped considerably in all ethnic groups. However, they haven't dropped enough in Blacks that the rates are approaching whites.
Can you speak a little more about the screening process and how patients should advocate at what age and what situations perhaps that they might be in to request screenings, because they're just not automatically recommended, right?
Absolutely. Screening for colon cancer is recommended for all adults in the United States. The only thing that varies is the age that you start screening. So if you are an average risk American, so that is someone who doesn't have a predisposing or high risk condition, and you don't have a family history of colon cancer, we recommend you start screening at age 45 or 50. And that will depend a little bit on where you live and your insurance carrier. There are some guidelines that recommend average risk Americans start at 45 and others that start at 50. But at the very latest, you should start your screening at 50. If you have a family history of colon cancer, so this is a mother, father, or brother or sister who has had a history of colon cancer, you need to start your screening earlier. You need to start your screening at age 40 or 10 years before the age of the earliest family member that was diagnosed. So for example, if you have a family member that was diagnosed with colon cancer at age 36, you need to start your screening at age 26. That's how we do that calculation. And then there are also a few groups that we're especially protective of. There are some individuals that have what we call inflammatory bowel disease. So this includes Crohn's disease and ulcerative colitis. Also individuals who've had radiation to the pelvis or abdomen for other medical conditions. Those individuals need to talk to their provider about starting screening before age 45 in many cases as well. So the important thing to take away is that everyone needs to be screened. And this is what I'm yelling from the rooftops and every day, is that everyone needs to be screened, but the age that you start your screening is what's going to vary. And that's why you need to talk to your provider about your particular risk.
But we're not seeing, as you said, number of African Americans being screened at the level that we should. So, and you talked about a number of factors. You talked about dietary, you talked about the environment, you talked about the family history, you talked about just the general lack of awareness. Those are so many areas around which we need to put our arms in order to see a change or see an impact. So tell us a little about your work, what you are doing in order to educate, create more awareness, and an effort to reduce the number of cases and get more African American screened. Could you tell us a little about your work specifically?
Absolutely. So as I mentioned, there are disparities along the full spectrum of cancer care, from prevention to early detection and screening, all the way down to treatment. Blacks and whites have different outcomes. Our team at UCLA actually focuses on that whole spectrum, but many of our projects focus specifically on the screening and early detection. And the reason why is because that's something we can actively advocate in community settings. And that is an area where African Americans and actually also Latinos and Asian Americans have not done such a great job at. We need to get more people screened. Historically in the United States, screening rates in Blacks were much lower than screening rates in whites. In the last 5 or 7 years, screening rates in Blacks have improved, but they still are not high enough. We need at least 80% of people to get screening on time. And now we're really closer to about 59 or 60% of Black Americans getting screening on time. So we have quite a bit of work to do. The work that our group does is we work in community health centers, federally qualified health centers, and also academic health centers like UCLA and academic centers like in the Veterans Affairs to make sure that patients are getting the information that they need to empower them to ask for screening, and to make sure that providers are remembering to recommend screening, especially in African Americans, when we know historically we haven't been done such a great job at providers as at recommending the screening. So these projects spread awareness. They teach people that colon cancer is common, but in many cases preventable. And they remind people that screening is essential because it helps us detect these cancers early. So I like to give this example to my patients. If I do your screening exam, the most common of these is a colonoscopy, and I detect your colon cancer when you are stage 1 disease, your chances of survival are 90%. However, if we wait a few months and we screen you later and your cancer has progressed, and I diagnose you at stage 4 disease, your survival is 11 to 15%, much lower. So unlikely that you're going to beat the cancer. This is why it's important to get screened early. Too often, our patients are waiting for symptoms. I can't tell you how many times in clinics patients have said, why do I need to be screened? I don't have any of the symptoms of colon cancer. That is not the point of screening. We screen asymptomatic people, people without symptoms. We screen asymptomatic people so we can catch the cancer before it starts causing symptoms. So that's something that we need to do a much better job at educating our community about.
When you talk about asymptomatic in this particular situation, what's described as an asymptomatic situation? Someone with a history who needs to be screened earlier? What determines asymptomatic in your work?
Yeah. And honestly, I shouldn't say most, but honestly, many colon cancers occur in people who have no symptoms of colon cancer. So what are the
Or
symptoms?
history?
Or history, or family history at all. So most of the cases that we're going to diagnose are people who have no family history of colon cancer and no symptoms at the time that we see them. Now, what are the symptoms of colon cancer? People who have colon cancer sometimes can have blood in their stool. It can look like bright red in the toilet bowl or in the stool. They can have a change in the shape of the stool. So the stool sometimes is described as pencil thin, or new constipation, new diarrhea, abdominal pains and cramps. And when the disease is very progressed, we see patients develop weight loss, fatigue, loss of appetite. So those are the symptoms of colon cancer, but our goal is to catch you even before you develop those symptoms. So if you come in for screening at age 45 or 50, we might find an early stage colon cancer in your colon, and you might not have any symptoms or any family history. And that's why screening is so powerful. And I think there's a little bit of a misconception that you only need to get screening if you have the family history or if you have symptoms.
So given now with the death of Chadwick Boseman, to what extent are you seeing colon cancer occurring more in younger people?
So this is an area that's receiving a lot of attention recently. So as I mentioned earlier, overall in America, the rates of colon cancer are going down. There is a subgroup, however, of people who are less than 50 in which we are seeing an increase in this disease. Historically, colon cancer was an older person's disease. The average age of getting colon cancer for men is actually 66 years old, and for women, it's 68 years old. So most people who get colon cancer are older. But since the 1990s, we are seeing more colon and rectal cancers in people who are in their 30s and 40s. And this is very unfortunate because, as I mentioned, we don't start screening until age 45 or 50 because there are many studies that show at a population level that is the most useful. So what we are seeing is that about right now, 11% of colon cancers are in this younger population that is less than 50. And that group of colon cancers is growing at about 2% per year, compared to the population over 65, where we're having a decrease in colon cancer over time. What do we do about this? Our younger adults need to be aware that they are also at risk for this disease. We can no longer think of colon cancer as the disease of the elderly. Even though most of the cases we see are people in their 60s, many times we're seeing this disease in people who are 30 and 40. I tell my patients in their 30s and 40s, number one, know your family history. If you have a family member, mother, brother, sister, father, who's had colon cancer, we need to pay special attention to you and we need to screen you early. And that screening is done with a colonoscopy to make sure that there are no cancers that are growing. But even in individuals who don't have that family history, you need to be cognizant of the symptoms. So again, if you're having blood in your stool, if you're having pain when you have a bowel movement, if you're having abdominal pain, weight loss, changes in how your stool looks, you need to see your doctor, because we need to take those symptoms seriously and we need to consider a diagnostic workup to make sure that you don't have an early colon cancer.
One of the things you said earlier in your presentation, the work you do with qualified healthcare centers, other community-based organizations. I find in the work that we do here at the Black Health, and we're a national organization with affiliates in about 11 cities, and because of partnerships with over 140 different groups nationally, getting information out there through not necessarily partnerships with the medical professionals is something of a gap. I think we need to look at how do we work more collaboratively between, say, health providers as yourself, with the kind of important work that you're doing, and with faith-based leaders, faith-based organizations, I should say, community-based organizations that are not health providers, to further get this information out there from different speakers or areas, providers, services, and community-based organizations. How, something that needs to be done in that area, because I see a big gap there. Yeah. We do this, you do that. The two needs to be brought together on a much more regular basis so that we can be more effective in what we're all trying to do.
I think that's a very important point. I agree with you 100%. What we're seeing is way too often this work to improve awareness and to improve screening is done in the hospitals. And sometimes they're done in hospitals where we don't even see minorities. So the first step is taking it to the community health center level or the federally qualified health center level. We need to go to places where people who are Black and brown are receiving healthcare. So that's the first step, right, is getting to the right health facilities. But then you're very right that there's a big proportion of the population that never even enters a health center. So how do we reach those people? And we actually did a study that I'm just remembering now on this a few years ago, where we took a focus group of African-American men and women, we sat them in a room and we had a talk about colon cancer. And we said, what do we as researchers and physicians need to do to get this message out there in the Black community? And you know what we heard? We heard things like, talk about this in my church. Talk about this, have information pamphlets at a Laker game or at a football game where I'm actually in a place where I can receive the information. Make this information available in commercials, in TV, and on the internet, places where I'm already naturally existing. And I thought that study was so powerful to me because I think as a healthcare professional, we so much are thinking about the patient in front of us. And we're thinking about the patients who actually come into the clinic. But there's a big group of people who don't even make it into the clinic. And how do we reach those people? And we need to do better with the messaging. A lot of us do give talks in churches. A lot of us work with pastors who help us spread the message about cancer prevention. There is some work that's being done at sporting events and community health fairs to spread the word. And there needs to be more of that and even more innovation about how to get this awareness and this information out there.
And I think in the midst of this environment we're still in with respect to COVID and how that has certainly uncovered so many of the disparities as they impact African Americans, Blacks and African Americans, that this hopefully has opened the door even wider to step in and talk about colon cancer and other diseases that disproportionately impact African Americans. Every time I hear someone say, oh, I'm so surprised, I did not know, my thought always is, Where have you been for the last decades upon decades upon decades when this information through research, reports, and everything else have been widely made available? So your point about needing to get it out there more and using information that comes out of focus groups is something that I hope we will be able to do more of. Now, Dr. May, with the limited time that we have, could do a couple of things for me. Number one, tell our viewers exactly how they might be able to reach you or follow up with any questions that they might have, and especially those out in California where you are located, that how can they reach you?
Absolutely. Thank you for that. I do want to say one quick thing about COVID, so I'm going to do that briefly. COVID is a unique opportunity for us to share and spread knowledge, and I think people are doing that. But people are staying home and they're also not seeking healthcare. So don't let COVID put a pause on your healthcare. Cancers will continue to grow. If you are due for screening, get your screening. We are doing safe procedures in the hospital. We're testing patients before having them come in. We're giving our providers the appropriate PPE. You need to get screened. COVID might be going on for some time. Get it done now. Do not wait. As for how to reach me or learn more about what we do, we actually have a website. It's the May Laboratory website at UCLA Health. If you just Google May Laboratory UCLA Health, you'll be able to see a lot of the work we do in health services research, cancer research, health equity, and also quality improvement. And there's some information there about our team and also how to contact us if you have questions. I'm also on Twitter. My Twitter handle is Dr. Fola May. That's DrFolamay. And a lot of people reach out to me there, so you can ask me questions there or tweet questions at me, and I will try to answer as many as I can.
Thank you so much. We never have enough time for these important discussions, but you have given us a lot to think about, and we will definitely be following up with you for more information. So I want to thank Dr. Fola May for joining me today, and she has told you how you can reach her, and of course, for information about NBLCH or Black Health, as we're known, you can go to NBLCH.org and follow us there. The Manhattan Neighborhood Network brings you these programs in order to better inform you, the viewer, about the important topics that impact all of our health and well-being. So please tell your family, friends, neighbors about the programming, and follow us on Twitter, Instagram, YouTube. And I am C. Virginia Fields, and I thank you so much for being with us. And we look forward to seeing you next time right here on Manhattan Neighborhood Network. Thank you.